Top Med Talk.
Hello and welcome back to Top Med Talk here at Anesthesiology 2024. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree, Chappell, your host, and I'm joined by the founding editor of Top Med Talk and co-host today, Monty Mythen. Hello, Monty. Welcome back.
Thanks, Desiree. It's great to be back.
It is great to be back. I'm glad you're in the chair, Monty. I know you've been a little busy bee around the meeting this year. Tell us a little bit more about why that is, and you're not in the chair the whole time.
Just over a year ago, I retired from the University of the National Health Service, took up a job with an industry partner, Edwards Life Sciences, as effectively their chief medical officer, and more recently, that component of Edwards Life Sciences, critical care component, has been acquired by Becton Dickinson. So I now work for BDAPM as their Senior Vice President of Scientific Liaison and Professional Education. So it's good to be liaising with you all.
Yeah. And that is what we do here on Top Med Talk. Just really quickly before we introduce our next guest, Monty, Top Med Talk is a leading perioperative medicine podcast you started about 6 years ago now, wasn't it?
Yeah. And the reason for that is that we thought we were having great meetings, but we were doing it in an echo chamber. And we needed to do better to broadcast it to the less well-resourced world in particular. This was all before COVID, before doing things virtually became very fashionable. So we started to effectively radio broadcast all of our evidence-based perioperative medicine meetings that have been running for over 20 years around the world. And then we grew that into a podcast very quickly. And we were hoping to get initially about 10,000 downloads was our ambition in, maybe 10 countries. And we quickly went over the million and over 100 countries. And now we're in the millions of downloads. Yeah. It's great.
Yes, we are. Capturing great quality content. Usually it started, like you said, at the EBPOM meetings, but we quickly transformed into sitting with guests here at meetings just like anesthesiology and learning more about what's happening in our field of anesthesia and perioperative medicine. So we're very excited about our next guest, one of which is the Top Med Talk fave. Has been on the podcast several times. So without further ado, we'll introduce Dr. Randall Clark, who was former president of the American Society of Anesthesiologists, I think a couple years ago.
2022.
Right, 2022. And recently retired professor of anesthesiology at the University of Colorado.
Correct.
And now we have one more title to add.
I am currently the board chair for the Anesthesia Quality Institute.
Fantastic. Thank you so much for joining us, Randy.
This is fantastic. This has been one of the great experiences the last few times I've visited with you. Appreciate this very much. And my daughters love the fact that I'm doing podcasts. So
that's awesome.
My value went
Shout out to the girls.
Yep.
What are your daughters' names?
Catherine and Victoria.
Hey, Catherine. Hey, Victoria. That's cool.
Thanks for he is very cool. Thanks for listening. And then we also have Marc Bernstein. Marc, so you are with the ASA, you're CIO of the ASA, but you also have a role with the AQI as well, correct?
About 2 years ago, a little less than 2 years ago, ASA's former, now retired CEO, Paul Pomerantz, asked if I could take over responsibility for the medical registries in the AQI. So I've been doing that for about 2 years. I've been with ASA for almost 8.
It was a perfect fit. Marc has done an outstanding job. While his background and expertise has been in information technology, it's been a perfect fit for what we have to do at AQI and the future work at AQI. So Paul Pomerantz made a great choice. And Marc, thank you for all your hard work.
What I would love to do is dive in first to what is the Anesthesia Quality Institute. We have talked to Rick Dutton in the past a little bit about it, but I think that it's moving in different directions and we haven't heard as much. So I would love to get an update on that. So maybe, Marc, we'll start with you and talk about what the AQI is.
Sure. So AQI is one of the related organizations of the ASA. So ASA has several foundations. Sometimes AQI is included in that list because we are technically a 501c3. Sometimes not, because we're not really a charity in the sense that we take donations and raise money through charity. We are funded by ASA and by that we bring in. So we're organizationally a subsidiary of ASA. So there's about 7 of us that are on staff at AQI, and we're all ASA employees as well.
Fantastic. And Randy, from the perspective of the clinician and an anesthesiologist, what is the interface and how do we interact with the AQI?
Everyone is invested in improving their care. And without having data to measure their performance, everything is really just a guess. In 2008, the ASA Board of Directors established AQI and has funded it since. And it has done really good work in 3 different areas that we'll talk about in a minute. But we're really at the cusp of going to the next generation of data collection and I hope data analysis to drive major improvements in care. It's hard work. We can talk about some of our exposure maybe without naming names. A lot of professional associations have registries, collect data, but it is difficult work. It's expensive, and sometimes the juice isn't worth the squeeze.
Yeah. So a question about that, because I am Vice President of Clinical Quality for North Star Anesthesia. So this is a subject very near and dear to me. One of the aspects of data when we talk about that and providing that back to our clinicians is the fact that we may have data related to like the merit-based incentive program. And those are the things that we have participate in registries to report back to CMS. But when it comes to true outcome data, there's a bit of paucity of that kind of data for many of us who are not participating in, other large or academic institutions. So is this something that the AQI is interested in?
Absolutely. AQI, beginning in 26 after MACRA established the MIPS program, has put most of its eggs into the MIPS reporting basket. We have several other features such as quality concierge that take that to a higher level, but that's where we've been previously. A lot of those MIPS measures are primarily process measures.
They are.
You report on a process that you've done in your continuum of care. We need to get more outcomes measures. You've seen the attention Dan Sessler brought to 30-day mortality last year in the Rovenstein lecture. That has been the subject of some of our journal publications, and the ASA Monitor has also addressed that issue. That, to me, is really the holy grail. We need to drive improvements in 30-day outcomes. To do that, we have to know what 30-day outcomes are.
Right.
Collecting that kind of clinical information is much harder than the administrative data that we've retrieved in the past. But there are some exciting prospects on the horizon that we're working on at AQI to be able to automatically and seamlessly collect much more clinical data, including discharge diagnoses and 30-day outcome information, if it's available in EHR. It's an EHR-based approach.
Fantastic.
To be fair to our global audience, because we have recorded a little bit in the past about MIPS, so we decoded that before. Just a quick reminder about what MIPS means and how it plays out.
Is the merit-based incentive program established by the federal government's Medicare program for quality reporting of individual practitioners and by group. The incentive is if you meet certain thresholds, you can get a positive increase in your Medicare payment.
Right.
If you do not report and are in the group that should be reporting, you can see up to a 9% decrement in your Medicare payments. And so that began set with the MACRA legislation. MIPS, I won't even try to get what MACRA stood for, but it was replaced the old sustainable growth rate formula that Medicare was working on prior to really move into a quality incentive program for Medicare payment.
And the CMS payments are your equivalent of a national health contribution from the government.
One portion, it's the federal portion for those over 65 and some with disabilities. The other partner group is Medicaid, that is a joint state federal program. Medicare, I think, and Medicaid payments are probably the majority of payments for medical services and anesthesiology in the country.
Thank you.
Yeah. And, we talk about the quality component of that. It's obviously on the CMS side and to do with payments. But we also have known that looking at process measures isn't all for naught. It does work as a nudge to help improve the quality of care that we're delivering, even though we may not be measuring outcomes at this point. So
Right.
up until this point, I think it has done a good job of raising awareness for some of the things that is evidence-based and that we should be doing in our practice. Would you agree?
Absolutely.
I would add the largest and the quantitative registry that AQI operates is the National Anesthesia Clinical Outcomes Registry, NACOR, which is NACOR.
NACOR, yeah.
We have on an annual basis about 15,000 clinicians that are contributing data into NACOR. And there's, I think, over 130 million cases. It's been around, and especially it accelerated in that 2016, 2017 time period. But we have a number of practices that participate in NACOR, and they're not required to or eligible to participate in the MIPS program. And they do find value in those QCDR measures that are part of the CMS program for benchmarking against other practices. We have national benchmarks as well as for negotiating with payers or hospital health systems. So yes, that's my long-winded way of agreeing with you. There's value, even if they're not the type of data we really are looking for to make leaps and bounds in providing quality improvement tools.
Mhm. So the AQI has been very active here at the meeting. So talk to us a little bit about some of the things that you're talking about and some of the activities that you've had over this past weekend.
Absolutely. Well, this Top Med Talk is one of our priorities, but we also have AQI safe tables. That's where we have experts give brief introductions on quality programs that you can institute at your department level or even at the individual level, and then vignettes related to problems that may occur. And it is a protected space so that the information shared there goes no further. So we hope people will be as frank as possible. Reporting on your own errors is always a difficult thing. So we wanted to create a safe environment for doing so. So we have safe table sessions both at the ASA annual meeting and also at the ASA advanced meeting, the practice management meeting in January.
Yeah. And Marc, you were saying this is your first year attending that safe?
Yes. So, I've heard of safe tables for a while. So I sat in on our 2 sessions. One was yesterday and one was today. And again, from, a non-clinical IT background, it connected some dots for me in my AQI role to understand how these sessions allow clinicians, or generally anesthesiologists, but clinicians to go through cases that come out of our AIRS registry, which is another one of our registries. AIRS is our Anesthesia Incident Response Registry.
Reporting system.
Report system, thank you.
Yes.
And that's a system where anyone can go to our website and submit anonymously and confidentially some incident or something that happened in their facility. And those are used, I've known them because they're used by our AIRS committee to write up cases that appear monthly in our Monitor publication.
Yeah.
And so those are really highly valued by our members. They're
Yeah,
some of the
for
top
sure.
10 read pages. And so to be able to hear what are the types of things that are being discussed, and then how people can take that information and bring it back in a systematic way to their institution about, hey, how do we prevent these types of things? Not that an individual did something wrong, but
Yeah.
where did the system fail? And
Yes.
so that was enlightening for me, and I really enjoyed sitting in on those.
Yeah.
AIRS has been a great addition to our efforts at AQI. It originated at UCSF in San Francisco. It's modeled on the aviation safety reporting system that is administered by NASA. It doesn't have all the characteristics of the aviation safety reporting system. There's a big incentive for users of the aviation system to report into that because it gives you presumptive immunity from any actions against your license. So we don't have anything comparable to that in medicine quite yet. Maybe we should look at that. But gathering lessons learned from both near misses and near hits really can help us to drive improvements in care.
Yeah, absolutely. I think we can learn so much from those experiences because all of us can relate, to many of the things that happen. Either it has happened to us, or colleagues or in our practice. And
I'll mention, I don't think you said it, but these activities are patient safe,
I was
PFO
just going to say patient
protected
safety. Yeah, yeah, we're gonna
activities. So this is confidential information.
Did you want to say something, Monty?
I do.
I got you.
Well, I think we're going to get there soon. I'm really enjoying the conversation. It was going to get to the sort of power of the data that you almost have within your hands with such a big country and so much digital data available. And then the tantalizing idea that we might be able to do these sort of adaptive trial designs, registry nested, answer questions quickly about fundamental things in the practice of anesthesia. But I didn't want to make that nice
You were
move too
chomping at the
quickly.
bit to ask that question.
I was.
Right now.
Is that-
You've hit on the thing that Marc and I have been talking about now for most of this year. As we look at improved data collection, that's only the first part of the process. We have to analyze that data and learn from it. We are pretty agnostic. Marc and I were at the MPOG meeting on Friday.
MPOG
Is the Multi-Center Perioperative Outcomes Group. It is originated at the University of Michigan in Ann Arbor, and it has Michigan hospitals, but now I think about 10 years crossed that bridge from just collecting the data, and it's been hard work for them. They've had to build EHR interfaces at each institution that they work in. They have now really flourished in the area of learning from the information that they've collected. So we went to that meeting in terms of that's the direction we want to go at AQI, and how can we learn them, potentially maybe even in the future partner with them to be able to drive the improvements in care that we need.
We and others in the room, we'll call it that, were at a great meeting in Prato in Italy earlier this year.
Yeah, this year.
Time passes so
I know.
slowly these days. And the MPOG group was there, and there was a fantastic presentation describing, as you described,
Yeah.
is that we ought to be able to really accelerate and make much more efficient and affordable the way we answer the fundamental questions. So bring it on.
One of the things that I think we don't talk about enough is you have to have the people asking the right questions.
Yes.
People that have the drive to learn from the information that we have. I think your career and what you've achieved both in Great Britain and here are fantastic examples of that. You're going to have to clone you or look to our primarily academic institutions, but also our large practices that have the resources to really encourage their own members to work in this area. It's so important that it is as important as the clinical care that we provide, to be able to give people the time to do the research, do the writing that's necessary for the dissemination of the lessons learned.
And Marc, from your perspective, from the informatics piece of this, how does that work?
It's hard. We're never going to get the data by having people check boxes or fill out data in a mobile app. It has to come directly from the EHR systems. And so one of the things that I work with Randy to do is spin up a new committee within AQI. It's actually across pollinated with some ASA members from some ASA committees as well. And that's one of the things that in my role, I've been able to help facilitate that because I'm also the staff representative on the ASA Committee for Informatics and Information Technology. And so connecting the dots, I'm hearing them talking about informatics and the CMIOs are over here. And AQI's like, we wish we had the data.
Yeah.
And I'm like, well, these people are playing with the data in Epic and in Cerner and in, Medtronics and all the other systems. So we spun up a work group. It's called the EHR Vendor Integration Work Group. Not very sexy,
Yeah.
but it describes what it does. And so what we're doing is trying to make direct connections between ASA and the EHR vendors and understand what are the steps we can do to lower the barriers to getting the data. Because what we hear and what everybody says is that getting a project through an IT
Committee
committee
and hospitals are impossible.
yeah, especially if you're an anesthesia group and you're not employed by that hospital, you're contracted, you don't have the leverage to be able to get on the radar, your projects are deep down in the backlog, and it just takes too long. There's got to be an easier way. And so that's really the path we're exploring. We're excited about some opportunities, but they're all still kind of potential right now.
Yeah. I think another exciting opportunity is once you get the data and having it presented back to clinicians in a way that we can actually use it, assimilate it back into our practice to change practice. And I think in some aspects, we've missed that mark a little bit on some previous generations of ways we've done this. How do you feel that AQI is going to lead in that space to really provide good, meaningful data that changes practice?
It's a big project, and it's not just AQI. So we work closely with groups like the ASA Committee on Performance and Outcomes Measurement. So they help us determine our quality measures. We use the data that exists within AQI to validate those measures and then propose them to CMS for inclusion in the future. And there are patient safety committees at ASA that contribute to our work at AQI. So it's really an all hands on deck experience.
Yeah, for sure. It wouldn't be one team to do it. So we've talked. Oh, yeah, go ahead.
I was going to say one more thing is that we have done it in the past, and I hope we do more of it in the future. As we collect more and more data or improve our ability to collect data, especially granular clinical data, partnering with industry is also an option for us. We had one, from our perspective, successful experience with Edwards on investigating Cleveland Clinic. So we hope to see more of those kinds of activities as well.
And I will say from that work has prompted a lot of work on the ground with frontline providers.
And can I just add a twist to that? Now I've spent more time working with industry. All of our partners around us here with all these wonderful technologies, they're very able to enable the more granular acquisition of data as well. They just need to see that that journey is being traveled effectively because, the correct date marking to make sure the date and clock is right on the monitors, to match the monitoring of physiological variables to the exact timing of the administration of fluids or drugs or whatever it is. It's all just hovering. It's all kind of just there, but they're not going to have the final push to make it really work well unless someone's doing something with the data at the other end.
Exactly.
Yeah. So it's all should work out well.
Well, let's talk about some of the other things that are happening here at the meeting. You said we're doing the safe tables. I know there was a little bit more activity, some posters that were being presented.
We have, I think, about 10 posters that are being presented during the meeting. And we also have medically challenging case presentations by participants in our AQI system. We are really looking to expand on that. And AQI has been in existence since 2008, but you can also always promote it more, which is why we were very happy to be able to participate in this Top Med Talk. We really want to get to the next generation. So we're working on programs for making quality improvement activities and using data to drive quality improvement at the resident and fellow level, one of our priorities for AQI. And that work has just begun this year. We've had conversations with ABA on how that would work in terms of the time that was spent in pursuit of that. But as we mentioned earlier, having the data is only step one. It's having the people that will use that data to drive improvements is the rest of the story.
And I would just add on to that. We had a summit of AQI leadership. Randy mentioned at the top of the call, we did it last January at the advanced meeting as well. And one of the things that came out of that was the need to reach the residents, the younger audience, and get them to be introduced to data and quality early in their career. And so this quality residency program, an AQI resident that we're putting together and proposing to the ABA is one of the outcomes of those discussions. Other things that came out that aren't directly related to acquiring data, but acknowledging and incentivizing people for their efforts to use the data. We're excited to announce that early November, we'll be launching a new course available to ASA's Shop ASA, the online learning system, for people, clinicians who are out, who are using data today for quality improvement. So it could be somebody who's using NACOR. It doesn't have to be NACOR. It can be another registry like an MPOC or just other data source for quality improvement. It's a way to get MOCA credit for the work that you might already be doing. And so we're excited about that. And if you want more information, contact us at AQI and look for it on the Shop ASA in November.
Yeah, absolutely. We always put the links to all of these things in the show notes.
Yeah.
So you guys are moving in a great direction and kind of infusing some, new direction to the AQI. What are you most excited about in this coming year? We've talked a little bit about getting the data, but what do you really feel like is where the rubber's going to hit the roads?
We have expanded the AQI Board of Directors, and it takes effect at the end of this annual meeting. We're bringing in some really great individuals, Irving Yee,
Yes, of course, a colleague of mine at North
and
Star.
others that have the kind of track record in quality that we really need. And so bringing all that additional energy and talent into AQI and helping us guide the organization, I think it'll be our biggest event of the next year.
Yeah.
If I could just mention real quick, I'd be remiss if I didn't talk about the third registry that we operate
Please
at
do.
AQI because it's our oldest. It's called Closed Claims.
Right.
And so this is the group started at the University of Washington with Karen Domino that looks at closed malpractice claims with the major insurance companies. They open their files to us. We have trained reviewers, physician reviewers that go in and look for elements that are either systematic issues that can be addressed or just educational pieces to tell people, don't get into this situation because this is the kind of outcome that can result. It's been one of our most popular educational subjects. Our closed claims lectures are always well attended. And as I mentioned, it's our oldest feature. ASA brought that on under the ASA and AQI umbrella, I believe, 10 years.
More recently, 2019,
Okay.
2020,
Right.
I think 2019.
It had been at University of Washington.
Yes. Yeah.
And so I'm sorry. So
Still access to that information is
yes.
really good.
But the new AQI board, what I sort of hinted at in terms of our ongoing work to dramatically improve, revolutionize clinical data collection, outcomes data collection, and looking for future partnerships to coming year.
Yeah, absolutely. And Marc, from your perspective.
So it's really about that EHR integration work group. I think there's potentially really great and exciting things coming from that. We have, blocking and tackling to do to make that stuff happen. We've done a draft data set for what type of data we would look to extract, and that's kind of our first step. And so I think we're going to, take that and take it to the next step and see, where we can make that happen.
Run with it.
Yep.
Well, working with multiple EHRs in the role that I have, there's just so much data, and it seems like it's such a shame that we can't use it to improve quality. So I commend the work that you guys are doing and putting all the effort from the ASA and the AQI into this. I think it's going to be really important and transformative, I think, for our profession and community in anesthesia. Gentlemen, thank you so much for sitting down with us.
Thank you.
Thank you.
You know what? One more plug. There is an opportunity for people to participate and share experiences coming up with the advanced
Yes.
meeting, correct?
We have another AQI summit on the day before. I believe it is Thursday, January 16th. We would welcome anyone that would have interest in seeing what AQI is discussing, our planning for the next year. Just contact Marc or me, and we'll get you incorporated into the AQI summit in January in Atlanta, I believe.
Yeah,
Correct.
that's right. Please reach out to them. Again, we'll put all the contact information in our show notes. So,
Great.
gentlemen, thank you so much.
Been great. Thank you.
Always a pleasure.
Great to see you again.
Good seeing you.
See you next year.
And thank you for listening to Top Men Talk. You can find us on social media, X, LinkedIn, Facebook, YouTube. We are there. If you find us there, subscribe to us. Subscribe to our newsletter at topmentalk.com. You get all the latest and greatest of conversations just like this that we have throughout the year. Thanks again for listening, everybody. Cheers.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.